Hi, my name's Julia Boster, and I'm a fellow in Pediatric Transplant Hepatology here at Children's Hospital, Colorado. My research focuses on muscle wasting in children with liver disease. Specifically, I want to understand how and why muscle wasting occurs and how it affects outcomes in children who require liver transplantation. Today, I will talk to you about a research project in which we studied sarcopenia in pediatric liver transplant candidates at Children's Hospital, Colorado. Sarcopenia is defined as a loss of muscle mass and function. This occurs in aging, but also in a number of disease states, including chronic liver disease. The data on how muscle wasting affects outcomes in adult liver transplant is robust. There's higher waitlist mortality, post-transplant mortality, and perioperative complications for adults with lower muscle mass. Although early data is starting to emerge in children, the understanding of sarcopenia and pediatric liver disease remains limited. But why do we study sarcopenia in children? Well, our standard markers of nutrition, such as weight and BMI, are unreliable in children with chronic liver disease. Organomegaly and fluid overload, occurring in the setting of cirrhosis, can confound these measurements, indicating that a child is more adequately nourished than they truly are. Furthermore, there are limitations to our standard markers of disease severity, i.e. MELD and PELD scores, which are used for organ allocation. With 1 in 10 infants and 1 in 20 older children dying on the liver transplant waitlist each year, there's an urgent need to identify additional markers of disease severity in order to determine which children with end-stage liver disease are at highest risk. With all of that in mind, we sought to compare muscle mass in pediatric liver transplant candidates to healthy controls, to describe the effects of sarcopenia on transplant-associated outcomes, and to compare the radiographic measurements of sarcopenia to MELD and PELD scores. We measure the psoas muscle surface area at the fourth lumbar vertebrae on CT or MRI by first locating L4 on the midline sagittal image, finding the corresponding level on the axial image, and using the Synapse 3D tool to trace the left and right psoas muscle, adding those together to get a total surface area. We chose L4 because it's well validated in the adult literature, and there is normative data in children for PMSA at L4 published by the Michigan Morphomics Group, allowing us to calculate a PMSA Z-score for every subject. From 2009 to 2018, there were 115 children listed for liver transplant at Children's Hospital, Colorado, of which 67 with clinically available cross-sectional imaging were included in our study. Age and gender-matched healthy controls were selected from a radiology database. You can see here that the weight and height Z-scores were significantly lower for transplant candidates than controls, representing the poor growth we typically see in the setting of chronic liver disease. However, the weight for length and BMI were not significantly different between transplant candidates and controls, which I think speaks to the inadequacies of these measurements in children with liver disease. The mean PMSA was significantly lower in liver transplant candidates than controls, which was still true after standardizing these measurements to height and body surface area. And finally, the PMSA Z-score was significantly lower in liver transplant candidates than controls. In terms of the effect on survival, you can see that there was an increased risk of death, either on the waitlist or following transplant, with a lower PMSA. This survival curve demonstrates the effect of PMSA Z-score on survival at 3 representative ages, 3 years, 8.5 years, and 14.5 years old. On the y-axis is the proportion of survivors, on the x-axis is time in months from imaging to death, and the different PMSA Z-scores are represented by separate curves, with green representing a Z-score of -2, red a Z-score of -1, and so on. You can see that survival was significantly poorer for a lower PMSA Z-score, and that the effect of PMSA Z-score on survival was more pronounced in the younger age groups than in the older age group. When assessing the difference via hazards ratio, there was a 1.7 times higher risk of death for every 100 millimeters squared decrease in the total PMSA value, and a 3.8 times higher risk of death for every 1 standard deviation decrease in PMSA Z-score. Finally, this scatter plot represents the correlation between the calculated MELD or PELD score, seen on the y-axis, and the PMSA Z-score on the x-axis. You can see that the PMSA Z-score did not correlate with calculated MELD or PELD score at the time of transplant. So in conclusion, pediatric liver transplant candidates have a significantly lower muscle mass than healthy age and gender matched controls, and those transplant candidates with lower PMSA had higher mortality, either while on the wait list or following transplant. Although PMSA was a predictor of survival, it did not correlate with MELD and PELD score, which are standard markers of disease severity and used to predict the risk of death without a transplant. Thus, sarcopenia may serve as an additional marker of disease severity and aid in risk stratification in children with chronic liver disease. I'd like to thank you for taking the time to learn about this work, and would especially like to thank all of my co-investigators and my mentor, Dr. Shikha Sundaram. Please feel free to contact me for any additional information.